Okay, so it's 12 o'clock, so we will go ahead and get started. My name is Katrina. I'm with the Michigan Opioid Collaborative, and today we have Alec Sheely with us presenting on marijuana exposure. The Michigan Opioid Collaborative has committed to doing a monthly webinar series, and we hope you'll join us for more webinars in the future. Everyone will be muted during the presentation. If you have any questions, please put them in the chat box and we'll get to them at the end. Also, if everyone could sign in the chat box with their name and email address so we know who's attending. If you would like to receive information on future webinars, please indicate that also. So I will go ahead and introduce Alec. Alec received her bachelor's in chemistry from the University of Missouri and went on to also complete medical school there. She did her pediatrics residency at the University of Kansas in Kansas City and also stayed to do a chief year. While there, she started her work with pediatric substance exposure, advocating with state legislators, sitting on newly formed opioid stewardship committee, and leading department conferences. She is currently in her second year of a pediatric hospital medicine fellowship at Helen DeVoe Children's Hospital in Grand Rapids, where she is researching pediatric exposure at all ages. In addition to hospital medicine certification, she is also pursuing the addiction medicine clinical practice pathway. After graduating this summer, she will be joining the faculty at St. Louis Children's Hospital, where she will be a pediatric hospitalist and help expand the adolescent addiction services. And I will turn it over to you.
Thank you so much. So I'm going to share my presentation here. Go. There we go. So today I'm going to be discussing the research that I've been working on for the last couple of years, looking at marijuana-related acute healthcare utilization related to the legislation changes that happened in Michigan a few years ago. Here is the link in the activity code so that you can get CME for this activity. I'll also have it again at the end of the presentation too. So if you miss it now, it's not your last chance. So I'm going to start with a patient case that actually kind of instigated the faculty interest in this topic. We had a 2-year-old child who presented to our emergency department in January of 2019 with a complaint of fatigue and subjective fever. Mom was reporting one day of this increased sleepiness, severe irritability, and she felt kind of warm. Maybe a little bit of congestion and some sick contacts at home because it was January and she is 2. But no difficulty breathing or cough, no vomiting or diarrhea, no rashes. Significantly decreased PO intake, having nothing in the last 12 hours and no urine output. So mom was really worried that her kiddo was dehydrated and brought her into the emergency department. They're actually not from here. They're visiting from out of town for a wedding and staying with a family member. Child's otherwise healthy, fully immunized. And as far as they know, their family member has arthritis, but otherwise no medical problems. And they weren't aware of anything in the home as far as medications or substances. In the emergency department, she had pretty normal vital signs. Didn't look toxic, but looked like she wasn't feeling well, and she was incredibly irritable. She wouldn't interact with the pediatricians at all. Her pupils were minimally reactive and 4 millimeters bilaterally. Normal strength, but overall very difficult to assess due to her agitation. Given how agitated she was, they actually did a pretty broad workup in the emergency department. She got a CT scan of her head, a complete blood count, electrolyte panel, urinalysis. They did an abdominal ultrasound. and a lumbar puncture on her, concerned that maybe she had meningitis. And then she was admitted for further workup and monitoring. Because she was persistently altered with her mental status, the admitting team did send a urine drug screen. And then around the time that she was actually transferred to the inpatient unit, her drug screen returned positive for THC, and everything else on her exam, on her workup, was completely normal. When mom had a chance to talk more to their family members, they discovered that there were actually a number of marijuana edible cookies in the home, and there were an unclear number that were missing. And so the end diagnosis for this child, who got a quite extensive workup and a hospital admission, was that she got into her relative's THC containing cookies. Still not sure how many she took. And she just needed some supportive care and observation until she was able to be stable and go home. So this case really has been interesting for us, because it highlights that history is kind of tricky when it comes to these kids, especially with some people still not feeling comfortable revealing to healthcare workers that they have THC containing products in the home. Also, if they're at a visiting visiting a family member or a friend, the parents might not actually know what's accessible in that child's environment. Edibles are incredibly enticing to children. If you think about cookies, brownies, candies, popcorn, those are all things that kiddos love. And it's already a problem that pills will look enough like candy that kiddos will get into them. And now you've got actual candy that contains a psychoactive product that can be accessed by children. So for this talk, I'm going to talk a little bit more about the scope of the problem, as in marijuana recreational legalization for pediatrics, and how it can affect my patient population. We're going to review the legislation changes nationally and what the legislation is in Michigan. Then I'll go into my project a little bit, and then talk about what we can do with the information that we've gathered. So it's crucial to note that as pediatricians or anyone who cares for children, that you're comfortable with the lingo, especially with adolescents. I've had a number of times where I've asked a teenager if they smoke, and they say no, and I say, okay, how about vaping or dabbing? And they're like, oh yeah, I dab. Or, oh yeah, vape. Yeah, I don't smoke, I vape. Because to them, they're very concrete, and they're genuinely not trying to be deceptive. You aren't using the right word. And so having an idea of the different methods of ingestion is very helpful, especially with marijuana containing products. And I have an entirely other, it can be a whole talk unto itself, but we'll just do a brief slide here. As marijuana is becoming more socially acceptable and legalization is kind of sweeping the nation, it's good to know, many people have heard that the pot of today is not like the pot of back in the 70s. And it's kind of nice to have a little bit of evidence behind that to know exactly where that comes from. The percentage of THC in plants that have been seized by the DEA has been increasing pretty steadily over the last couple decades. And previously, prior to the 2000s, CBD content was actually higher than, oh, it's not higher than THC. Sorry, I was about to misspeak there. But it was higher, and now it is being, plants are being bred to have lower CBD content. And CBD actually kind of helps mitigate some of the negative psychoactive effects of that THC. So it's not a great thing that we're increasing the psychoactive content and kind of decreasing that CBD, which can potentially have a little bit of therapeutic effect. So because legalization has been happening for a number of years now, we have had some time to learn from poison control how this has affected pediatric patients. In Colorado, after recreational legalization, pediatric marijuana-related poison control calls tripled. 74% of them were ingestion-related. A quarter of them were related to just other questions. And then the vast majority of them were happening at home, as opposed to at a friend's house or babysitter's house or playground, wherever. And then when they looked at children that were evaluated in the Colorado Children's Emergency Room, they looked at what kind of product those kiddos were ingesting. And about a third of them were ingesting products that were intended to be for medical marijuana use, and half of them that they could determine were actual recreational products, such as cookies, brownies, cake, candy, and popcorn. We've also been able to look at national poison control data, comparing non-legal states versus states where recreational marijuana is legal, looking at pediatric cases. Unsurprisingly, rates of accidental ingestion have remained pretty steady in states where legalization has not occurred. They don't have so much CNS symptoms, somnolence, ataxia, altered mental status, and their duration of symptoms are pretty short, and they often are able to just go home. However, in states that have legalized recreational marijuana, rates are increasing. They have more profound ataxia and altered mental status, and they are more likely to require admission to the ICU, not just to the hospital. So when we look at adolescent perception of marijuana with the national trend, when we look at their perception of risk of substances like cocaine, heroin, binge drinking alcohol, it's pretty consistent that many teens see that those are risky behaviors to partake in. However, consuming marijuana, that risk is very much perceived as low. And some of the great information from Monitoring the Future, this is through 2019. I haven't updated this slide with the 2020 data that came out recently. But if you look all the way over to the left is the high schoolers who see a great risk in using marijuana regularly, and it has been downtrending over time. And if you notice, 12th graders, the oldest of the group, have the lowest perception of risk. And if you look at over on the right, the vaping marijuana or any vaping, the group that uses the most are our 12th graders. So there's some correlation between a lower perception of risk and more use of that substance, which is not terribly surprising. It's also concerning because, let's see, it was 2019 saw the second largest increase ever measured of a single substance increase in use. in adolescents, and that was in vaping marijuana. Teens are vaping more than they're actually smoking, and they're using more concentrates. So three-quarters about of teens who have tried marijuana have tried concentrates. So that's that THC wax or the dabbing material that they'll heat up and get a quicker, stronger high. That's commonly referred to as dabbing. And that's concerning because that quicker, faster high puts teens at a higher risk of going on to develop a substance use disorder. It is worse on their brain, which makes sense. And it actually increases their likelihood of developing psychosis. So part of the reason legislation has been changing so much is not only the decreased perception of risks for the general population, but also all the perceived benefits from medical marijuana, which have been limited in their studies partially due to the legalization status. THC itself might be effective for chemo-related nausea, MS-related spasticity, and could potentially help with chronic neuropathic pain, but some studies I've read seem to have kind of mixed thoughts on if it helps chronic pain or if it increases opioid misuse. But it doesn't seem to, THC doesn't seem to be better than other methods of analgesia. CBD actually has a little bit better studies behind it, not the psychoactive component. The CBD itself has been shown to help with epilepsy. So we have a number of kids with complex seizure disorders who are getting some seizure relief on a medication called Epidiolex, which is a CBD based drug. But overall, more studies are needed on this, and legalization status might actually assist in it. Risks are also poorly understood because of the changing THC content over time. Decrease, it's hard to quantify like true exposure in adolescents or adults or in pregnant women. How much THC they're exactly taking and what that end outcome is going to be. But there are a number of potential risks from in utero exposure to the unintentional exposures, which is a good chunk of my talk today. Immediate effects like cannabinoid hyperemesis syndrome and E-Valley, which was a thing that we were really paying close attention to right before the pandemic hit. Its effect on mental health disorders, and then more chronic conditions as well as lung disease and cancer. There's, I think we've been a little bit behind the curve on advertising for, marijuana is natural, so therefore it's safe to use in pregnancy and is an appropriate alternative to other methods for morning sickness, methods to combat morning sickness. We do know that there is an associated with marijuana use in pregnancy and babies being small for gestational age. Unclear how it affects prematurity. Does not seem to induce a severe abstinence syndrome like opioids can. And there's kind of mixed evidence as far as long-term neurodevelopment, but it seems to be correlated with long-term issues with problem solving, actual memory formation, and impulsivity, as well as problems regulating sleep. Interestingly, in Washington, after marijuana was recreational marijuana was legalized, the percentage of traffic deaths that were related to marijuana nearly doubled in the year that retail sales were allowed. So even though driving under the influence of marijuana, just like driving under the influence of alcohol, is illegal, people are doing it. I know when I was younger, I heard jokes of like, well, if you're high, you're not going to want to get up off the couch and, you know, stop with your munchies to go drive. But people are driving while they're under the influence of marijuana, and it greatly increases the risk that they will have a fatal car accident if they do have a car accident. And then the final thing I want to chat about a little bit before we go into the legislation details. This is from SAMHSA. When we look at adolescents who use other substances like opioids or alcohol, or are diagnosed with major depressive episodes, if you look at those adolescents and then you categorize them by how much marijuana they have used in the last year, there seems to be a significant correlation between regular marijuana use and increasing misuse of other substances and worsening of depressive episodes. It's not clear if the correlation between depression and THC use is causative or exacerbative, but it is concerning. And what we've seen, especially in the last year with COVID, is that mental health admissions are increasing, and we are seeing more and more adolescents who are admitted with depression and suicidal ideation who are using THC products in one form or another. And it really is unlikely to be helping. Kind of giving away a little piece of my talk later, but it all fits together. Okay. So let's briefly talk about the actual legislation. This map, I believe is up to date through like January of this year as far as what states have legalized. There are various forms of legalization. You can have fully illegal, like in Kansas where I trained, or you can have decriminalized marijuana, which is a fantastic step towards equity, racial equity in our justice system with regards to substances in general. Some states will have medical legalization without decriminalization. Some will do medical legalization and decriminalization. And then the dark green states are complete recreational medical legalization. South Dakota passed, they voted on a resolution to legalize recreational marijuana, but that is like tied up in their court system. So it's unclear if they're actually going to go the way of turning dark green or not yet. I believe that court date's actually set for this month. So Michigan specific, medical use has actually been legal since 2008. And a lot of the specifics of the legalization is actually carried over from the 2008 medical legalization. 10 years later, 2018, we voted to legalize recreational use with Proposition 1. Shops were able to obtain permits in December of 2019 and actually start open for use. And as of June of 2020, recreational sales were outperforming medical marijuana sales. This infographic is old. It's before recreational shops were able to actually open, but I think it's still a good summary, kind of the high points of the legalization. So it's still only legal to those who are 21 and up, You're limited to 2.5 ounces that you can possess on your person, 10 ounces that you can keep at home. If it's above 2.5 ounces, you're supposed to be keeping it locked away. And you're allowed up to 12 marijuana plants that you can grow yourself in your home, which is the highest of any other state like limitations that I've looked at, by a lot. Most other states are limit you at like 6. And this actually is one of those carryovers from the medical legalization. Still not allowed to drive under the influence. You can't do it in public, unlike some spots in Washington. And municipalities can actually decline to allow sales. They can't ban consumption, that's statewide, but some towns can opt to not allow dispensaries. There is also a provision that the sales tax, 10% of it's supposed to go to K through 12 schools, and a certain percentage of the sales tax is supposed to go to the state for infrastructure. Although it sounds like I'd be interested to see if those funds actually make it to where they're supposed to, because in Washington, they have actually not, they have similar provisions, but the funds have actually not made it to the school system like they were, like they're supposed to. And since we're not the first state to legalize recreational use, there are limitations that are meant to help children. Specifically, edibles are not supposed to be sold in packages that are attractive to children or confused with a non-marijuana candy brand, such as these packages that you can see here in the lower left. As an Oreo lover myself, I don't know that I would, really notice that that is not, in fact, an Oreo package there on the bottom left if I were a child who just wanted to get into some cookies. Packages are supposed to be opaque and resealable and child resistant. And it's important to note child resistant, not child proof. If things were truly child proof, most adults would not be able to get into them either. It's just supposed to be difficult for a child to get into it, not impossible. It's another example of a display that is not compliant with these limitations. And a retailer is not supposed to be within 1,000 feet of a school, which sounds great, but if you really look at how far away 1,000 feet is, it's really not that far of a distance. Going back to Colorado data, they actually have very similar limitations. We took our legislation almost straight from Colorado, with the exception of we don't have any provisions about limited marketing or dose limitations. However, these provisions did nothing to truly stop accidental ingestions. These limitations in Colorado weren't initially in place, and the community voiced their concern about increasing accidental ingestion rates. So these provisions were put in place. And the only significant change that happened was that the average age of accidental ingestions went from the age of 2 to 3. So it took a slightly older child to get into the packages, but ED visits and poison control calls continued to increase. So they make us feel better, but they don't really seem to work. And I have a suspicion that it's because they are not truly enforced, which I can go into actually in a little bit. So looking at what's been happening in our region. My study, the aim was to investigate the incidence of THC exposure going back to 2014, and we've collected data through 2020. We see a good number of children at our facility. We have 9,000 births through our birth center about every year, roughly 9,000 admissions a year, and then 50,000 ED visits a year, 55. So we did a retrospective chart review, and we pulled all encounters that were patient age less than 18 who had either meconium drug screen or a urine drug screen that was positive for THC. And then since that's a pretty big data set, we've broken it down into a couple different groups to look at what all's going on in our community. So we got meconium drug screen and urine drug screen results, so all the components, so we could look at co-ingestions. And of course, we looked at our demographics, our sex, reported race, and then we also pulled associated diagnoses codes. And then we looked, we've started with just straight rates of positive tests for the number of encounters we've had over the course of a year. And we're just starting to dive into the associated diagnoses, especially as they relate to adolescents. So our newborn results, what we've seen is a steady increase over time with our rates of newborns who are being born with meconium that test positive for THC. And it's worth noting that actually over this time, our protocol at our birth center for testing for meconium drug screens really hasn't changed. And when we chatted with the OBs that most often admit to our hospital, their protocol for screening mothers hasn't really changed over this time either. So, 2014 to 2016, we saw a pretty steady rate of about 5 babies per 1,000 births who were being born exposed. And then in 2017, we start to see an increase. And in 2019, the year after recreational legalization, we see the largest increase. 2020, interestingly, the rate went down a little bit, but we're still, we're staying over that pretty steady state of 5 per 1,000 births that we saw pre-legalization. When we look at co-exposures, most common was opioids in various forms that we were able to test. A few babies with amphetamine exposure, and then a couple with cocaine and barbiturate exposure as well. Accidental ingestions was also very concerning to us. Pre-legalization, we actually had very few cases of children under the age of 12 who were admitted to our hospital or even came into our emergency department who were tested to be positive for THC. And in the years after, it's kind of skyrocketed. 2019 to 2020, our rate more than doubled. What's also really concerning is that before 2018, of all those patients that are represented on this graph, only one of them required ICU admission. However, after 2018, half of the patients that are represented here have needed to be admitted to the ICU. The dark green line here actually represents children that were seen in our emergency department and were well enough to go home. And that has increased a little bit in the last year, but has actually been fairly steady and not significantly changing, unlike our admission to the hospital rates, which was part of our concern at the beginning with that case that I initially talked about, because that child is they get an extensive workup because they come in with a profound altered mental status and some pretty profound ataxia too. And so they'll get seizure workups, they'll get meningitis workups, they'll get all kinds of imaging and testing, and they actually might need some medications to help with their ataxia or their agitation. And they might end up in the ICU getting charged for an ICU stay, when really, if they could have just not gotten into that cookie, they could have avoided all of it. Yeah. So we've been able to demonstrate an increase in pediatric THC exposure, especially in our newborns and in our younger children. And we believe that recreational legalization has had a large impact on this, as well as the increased retail availability that happened in the year 2020. Interestingly, adolescents haven't actually been admitted with, oh, interesting, it just keeps going without me clicking. Okay. Adolescent admission rates have actually, they've been kind of up and down through the whole course of the study period, but they haven't seen as big of a change with recreational legalization as we've seen with as we've seen with the younger children. We are looking at their associated diagnoses codes, and far and away, adolescents are being admitted with depression, anxiety, and suicidal ideation. The ones who are THC positive, that's easily their most common reason for admission. And what we've noticed just at the start of sifting through all of the data that we have is that the adolescents being admitted with an associated psychotic episode has actually increased dramatically pre versus post legalization. So the rates of adolescent hospitalization with positive THC hasn't seemed to, there isn't as clear of a correlation, but the symptomatology seems to be a little bit more severe. And the other things that this graphic is showing is that patients who are transferred to our facility from another region who tested positive, like at an outside facility, they don't show up in this data set. It's only patients who tested positive at our facility. So we know that these numbers are actually a little bit higher. The patients who only test positive on a comprehensive drug screen, so like a blood test, as opposed to a urine drug screen, just logistically with how things report out in our EMR is not really feasible for us to pull that data with this data set. So we know that we're missing those patients as well. But it doesn't seem to be a huge number. We primarily do urine drug screens. Let's see. So finally, what can we do with this information? I think the biggest thing that we can do is we can talk about it with not just with adolescents. The not so great correlation between marijuana and worsening mental health, the dangers of driving under the influence or driving with someone who's under the influence, the risks of e-cigarette or vaping associated lung injury, not just with teens, but with parents. And I think this is one thing that all PCPs could increase their comfort with is, if you're the type of person who does safety screening with the family and you're asking, all right, do you have, gates at your stairs for your toddlers? Do you have locks on your cabinets? Do you have guns in the home? Do you have marijuana edibles in the home? Adding that in there so that they're aware of the need to keep those things locked away and away from children. Not long ago, I had a child admitted to the hospital with accidental marijuana ingestion, and the parents insisted that, oh yeah, we have edibles in the home, but there's no way the kid can get to it. And after all the workup, there was no seizure disorder in the kiddo, and they were very positive for THC, and they were kind of shocked. Like, so let's talk about what you're actually doing to keep the pot brownies away from the 5-year-old who clearly is going to love brownies. I also think talking to legislators, this is something that I've had the wonderful opportunity to do. And I think it can be incredibly helpful, especially because letting them know that these, that these provisions that we have in our laws really probably are not as helpful as we think they are. And so we need to be taking a different approach. One of our residents at the hospital came to me with wanting to work on this project because they had a kid that ate a bunch of THC gummies, and the parents had the packaging, and you could not tell unless you knew it was an edible from a dispensary that it had THC in it. Like, it was so hard to see. So the legislation on, or the limitation on packaging not being confused with a candy brand or not appealing to children is absolutely not being enforced. And so we're going to, our intent is to take this data to the Michigan AAP and to other community advocates, so that we can help disperse education and brainstorm ways that we can have a community effort to keep our kiddos safe. And I think getting familiar with resources goes all along with that. So there's a website, Smart Approaches to Marijuana, which I think is a pretty cool website that has some of these one-pagers that has, they have legalization quick facts. They have some like quick Q&As about marijuana exposure. And they have politician info, which clearly I enjoy being able to talk to politicians. But you can look at your region and look at your representatives and see who has contributed to their campaign funds. And it's not just marijuana, it's also like big tobacco. Like, you can see how much money they've gotten from lobbyists who support various substance legislations. And then SAMHSA's website also has wonderful links to things that I think are very printable and like great to hang up in your office or have on a counter somewhere. And some of them are really wonderfully geared towards teens. They have great like pictures on them, which I think really helps convey a message pretty quickly. So here are some of my references that I learned, or that I used in my talk today. And then there's the smaller version of the activity code, and then my email. And if we have time, I'd love to answer any questions. Thanks for coming, and thanks for listening.
So yeah, thank you, Alec. If anyone does have any questions, please type in the chat box. And also remember to sign into the chat box for attendance. There looks like there was one chat or one question in the box. It says, is every newborn tested? I'm guessing that's what.
No. So mothers who either tested positive for any substance during their pregnancy will get a meconium drug screen. It's pretty typical that mothers who are late to access prenatal care, I initially thought that was a pretty judgmental thing for us to do, that if a mom was late to access care, that we should get a drug screen, but there actually is a correlation with not accessing consistent medical care during pregnancy and substance use. Let's see. And then if they present with placental abruption, since that is highly associated with cocaine use, those babies will also standardly get a meconium drug screen. Those are the three most common reasons that we'll get one. And then some facilities will have a handful of others that I just can't recall off the top of my head. But that's a really great question.
Okay, so what is the protocol or proper action if someone is deemed abusing their medical card? For example, someone is referred by the court, suggested to get a medical card to smoke while on probation and meets diagnostic criteria for cannabis use disorder severe.
Ooh, that is a fantastic question that I'm probably not well equipped to answer, because my patient population is all pediatric and they don't get medical marijuana cards. So I'm really sorry, I can't answer that.
And then there looks like there's one more. Does HDV refer connect with CMC or CMI, or just dependent on specific drug use?
Yeah, so that's going to depend on where the child lives and what resources they have. And that's our social workers and behavioral health team are actually in charge of that. I feel like the majority of them go to CMS.
Any other questions at all for Alec? Is there a campaign toward adults or kids on packaging?
Oof. You know, I think we're probably going to start looking at that now that we have this information that the packaging is clearly problematic. So I don't know, and I hope there is. If not, there will be advocates at Helen DeVos that are going to be working on that.
We see cannabis-induced psychosis a lot in the EDs. What about peds?
Yes, so that seems to be occurring more often in adolescents after recreational legalization, and I don't think it is being recognized until they are admitted, and and then all the testing comes back that they are positive for THC, and things seem to be THC related. So we're not used to seeing it, but we have started to see it more. And unfortunately, because we're not used to seeing it, they're getting the big workup.
Do they do a UDS as part of proactive versus CT?
So it kind of depends on the ED provider and how the kid is presenting. So they alter. So if the kid is coming in very somnolent or altered, they are quicker to get a urine drug screen than they are if they're coming in with ataxia or a seizure-like presentation. Some of the kids are also coming in with respiratory or like palpitation-like episodes, and they are especially not getting diagnosed until after they're admitted. But we're quicker to test for ingestion if the kids are more agitated or asleep than if they're presenting looking like a seizure.
I think that was all the questions in the chat. Any other questions? Okay, well, thank you, Alec, for your time and for everyone who attended. A behavioral health consultant will be following up with everyone who attended, and you can reach out to them for with any questions or if you need any additional information. A recording of this webinar will also be posted on our website, MichiganOpioidCollaborative.com, within the next couple weeks. Oh, whoops, it looks like there is one more question that came in. It says, are they doing studies on older, like 20 to 30-year-olds?
Yeah. Because I'm looking at patients who are not supposed to be having access to these medications, my research actually stops at the age of 21. But I know that so we're having our trainee research day, or research week has started, and I've seen some posters around our hospital actually looking at various case reports of adults being admitted with marijuana related illnesses. So I know there is some interest, but I haven't yet had the time to connect with people at our institution who are looking at the effects of marijuana on the non-pediatric population. But just from one poster I looked at, they are looking at THC vaping related strokes in young adults.
And one other question, do you think the federal government will eventually legalize marijuana in all 50 states?
I think that's where we're headed, yeah. Oh yeah, it very much affects the GI system. Sorry, I just got the chat up on my other screen.
Oh, no problem.
Yeah. Yeah, it very much affects the GI system. And that was actually one of my interests when looking at the diagnoses codes for adolescents. I was looking at how much hyperemesis and nausea and vomiting we're seeing. And it's definitely a smaller subset compared to the mental health children that we're seeing. But yes, it especially in adolescents, it very much affects nausea and vomiting. And man, on my end, when they're admitted for nausea and vomiting and it seems to be worsened by their marijuana consumption, it is hard to convince them that that is in fact the case. So that is actually a very difficult thing for hospitalists to encounter. And because I just started sifting through the associated diagnoses codes in our adolescents, I actually don't have a great idea of how many nausea vomiting cases we're seeing.
Any last questions for Alec? I will leave the chat up for a little while in case anyone needs to do any last minute signing in, or if there are any last minute questions, I can forward those to Alec and then we can send out her responses later on if that is the case. So thank you so much, Alec, for being here. Thank you for a great presentation.
Thank you. Happy to do so.
And I hope everyone has a good rest of their afternoon.
Thank you.